Okay, and we're back. Okay, I think everybody needs to take a deep breath. And Sophie said that she's unsure whether she could finish the talk, Dr. Susilo. All right, so we come to the very end. So this is our final session. As I already mentioned before, we're going to discuss about obstetric anesthesiologist, obstetric anesthesia. So I've seen a lot of questions in the first session. So I hope we can still have a lot of discussions. For this, we will have three speakers. The first one, I think you already know because she was the moderator in the past session, Professor Anne-Sophie from France. And the second and the third one coming from UK. I believe it's good afternoon, right? Or still good morning?
Good morning.
Morning going to the afternoon. So Dr. Nuala Lukas and Professor Mike Kinsella. And for closing, I will invite Dr. Susilo Chandra to be the chairman of this session. Please, Dr. Susilo.
Thank you, Krisha. So, hey, Jude, still in my mind. I cannot stop. I have to move on now. Thank you, and we can start. Good afternoon, everyone. As Krisha already mentioned earlier, in Indonesia, we traditionally to open and close the symposium with obstetric anesthesia. As an anesthesiologist, obstetric anesthesia has been my passion, and also the music as well. In the past decade, we have seen many improvements in the field as shown in past session. This afternoon, we will have three distinguished faculty. All are my friend and my beloved colleagues in this field, Anne-Sophie from France, Nuala Lukas and Mike Kinsella from UK. I invite all participants to give questions. So without further ado, I would like to invite Anne-Sophie to give her talk.
Thank you, Susilo. Thank you for your invitation to share our research and their implication for postpartum hemorrhage. I focused my talk on tranexamic acid in obstetric acute coagulopathy, and I have no conflict of interest regarding this theme. Obstetric hemorrhage remains the leading cause of maternal death worldwide. The caregivers' mobilization in France have been able to decrease the PPH-induced maternal mortality from the first to the fifth rank of all deaths. However, some hemorrhage remains intractable, and coagulopathy have been identified as a major cause of management failure. PPH management is a multidisciplinary challenge and needs anticipation, organization, and team training. The management of coagulopathy is included in the patient blood management with the 3 stages of detection, treatment, and follow-up of the treatment. The 2 major components of coagulopathy are fibrinogenolysis and fibrinolysis. There are large variation of the occurrence, of the intensity, and of the evolution of the coagulopathy, supporting the real interest of viscoelastic test diagnosis in this context. There is a recent Cardiff team trial which selected all severe hemorrhage in the gaze, and they detect coagulopathy in 20% of the postpartum hemorrhage, but they found coagulopathy in every amniotic fluid embolism and in all the severe with fetal death placental abruption. Sorry. The clot formation is the proteolysis of fibrinogen by thrombin. Thrombin is a key enzyme of coagulation. Thrombin leads to creation of the fibrin monomers, then native fibrin, and stabilized fibrin by a polymerization process. Fibrinolysis is the lysis of fibrin clot by plasmin. And plasmin is the activated plasminogen by a tertiary complex of tissue plasminogen activator and plasminogen co-localized on the fibrin, native fibrin lysin site. The proteolysis of the stabilized fibrin is fibrinolysis, and this produces D-dimers. Tranexamic acid blocks the link between the native fibrin and the plasminogen, and thus inhibits the TPA plasmin generation, but not the UPA plasmin generation, and this reduces the D-dimers and the plasmin-antiplasmin complex production. Tranexamic acid has demonstrated its clinical efficiency. Tranexamic acid is a cheap, easy to use, easy to conserve drug, and has been classified as essential by the World Health Organization. What we know is its efficiency in the trauma and the major surgery to reduce blood loss and transfusion need. There are major side effects in cardiac surgery, which are phasers. The first evidence of clinical efficiency was demonstrated in PPH after a high dose of 4 grams that limited the bleeding volume and the bleeding duration, and also the need of transfusion and maternal morbidity. The large international randomized placebo-controlled study Woman demonstrated that a single dose of 1 gram was able to reduce maternal mortality due to bleeding, but not global mortality and the rate of hysterectomy. And there was an optimal administration time of 1 to 3 hours after PPH onset. Woman trial needed 12,000 parturients recruitment in the low-resource country and gave also a very important message of safety of tranexamic acid regarding no excessive risk of seizure, neither renal failure, neither thromboembolic events. Because of the optimal administration time interval, prophylactic use of 1 gram of tranexamic acid has been suggested. There are 2 large French prospective randomized trials versus placebo, the TRAP trial for vaginal delivery and the TRAP2 trial for elective cesarean section. Prophylactic use had a smooth impact after cesarean section by reducing the rate of PPH more than 1 liter. But in this study, the rate of PPH more than 1 liter was a little bit higher than expected. There is now a large US trial of 12,000 patients, and it's in running of publication, and the prophylactic use did not demonstrate any impact on blood loss reduction. Did tranexamic acid demonstrate a reduction of the biological markers of hyperfibrinolysis? In Exadeli trial, we found that the high dose of tranexamic acid reduced the D-dimers and the PAP increase due to PPH. Here is a black round is a untreated hemorrhagic patient, and the red stripe are the tranexamic acid treated patient. And there was no impact on fibrinogen decrease and factor II decrease. We confirmed this result with the new TRUST trial, which is also submitted for publication. And we included 220 cesarean sections, out of which 175 were hemorrhagic. And we made placebo dose ranging trial, randomized, with a low dose of 0.5 gram and a standard dose of 1 gram of tranexamic acid. TRUST trial was not designed to demonstrate a clinical impact versus placebo on maternal mortality and total blood loss. But we found that the 1 gram group has a better reduction on additional blood loss than the low dose group. This effect was confirmed by a dose effect reduction of hyperfibrinolysis in the 1 gram group, but not in the low dose group. In the placebo group, we observe at the second hour an hyperfibrinolysis marked by the D-dimers increase, and this hyperfibrinolysis was inhibited in the standard group dose. This is also observed by the plasmin-antiplasmin complex increase observed in the placebo group at 30 minutes and also at 1 hour, and it was inhibited in the standard dose group and not in the low dose group. We confirm this effect by an ex vivo thrombin-plasmin simultaneous generation test assay, and this demonstrated that the time to reach plasmin peak and the interval time between thrombin and plasmin peaks was reduced in the tranexamic standard dose group, but not in the low dose group. We had no impact of the standard and the low dose groups on thrombin generation nor fibrinogen decrease, like in Hexadelete trial. We created a pharmacokinetic model out of 79 patients and 385 blood concentration measurements and 117 urinary concentration measurements. We found that the best model was a bicompartmental model with a double first order elimination from central compartment. We observed that the model was better with when modulated by body weight before pregnancy, and that the clearance of urinary elimination was proportional to the renal clearance. What is very interesting is the non-urinary elimination, which goes from 25 to 50%. And this could be the leakage of tranexamic acid sorry, in the hemorrhagic group, or consumption in the antifibrinogen process. Sorry. Thus, we can say that there is a large research effort about this essential drug, which is tranexamic acid. And we found that there is a clinical dose effect of tranexamic acid, which is confirmed by biological inhibition of hyperfibrinolysis. And these results are in favor of the use of at least 1 gram dose when the bleeding is active. These results are different from Analgesia and all results testing a PK/PD model in 30 plasma of elective Caesarean section patients. And out of their study, they preconize a low dose of tranexamic acid to inhibit fibrinolysis. However, they had no clinical criteria, no urinary concentration, and the higher dose was upper limited to 1 gram. And there were only non-hemorrhagic patients. And we know that prophylactic tranexamic acid is slightly efficient. It remains a lot of questions. Why have we an optimal timing of 1 to 3 hours? Is that due to the high hemorrhagic flow and the leakage of the product in the high hemorrhagic flow? Is that due to the fibrinolysis after 3 hours, which is generated by UPA, and tranexamic acid doesn't act on UPA? Do we need to adapt the dose to the fibrinolytic activation? Do we need to administer a second dose if bleeding continues? I show you this case of a clinical case of an elective Caesarean section. We demonstrated a transient circulatory arrest and loss of consciousness just after birth. We immediately think to amniotic fluid embolism and make it our protocol to treat and prevent the large bleeding. And we made a ROTEM and observe a very intense fibrinolysis and fibrinogenolysis despite the very low bleeding volume. And this was confirmed by the lab test with a 1,000 time normal range increase of D-dimers. So a very intense measure hyperfibrinolysis and the decrease of fibrinogen in 10 minutes. So coagulopathy is an entity by itself and independent for bleeding volume. And in this case, we needed 3 grams of tranexamic acid and 9 grams of fibrinogen concentrate, and also fresh frozen plasma to correct the coagulopathy, so independently of bleeding volume. Can we expect from tranexamic to correct the fibrinogen decrease? We have seen in TRUST and auxiliary trial that tranexamic acid did not influence the thrombin generation and did not modify the fibrinogen decrease. Thus, fibrinogen supplementation have to be parallel to the tranexamic acid antifibrinolytic action. And this could be done with fibrinogen concentrate or cryoprecipitate, depending on what is available in your country, or fresh frozen plasma. And at the best, it should be guided by thromboelastometry. In conclusion, TRUST is the first study to determine the tranexamic concentration required to stop hyperfibrinolysis after the beginning of hemorrhage in Caesarean section. In this context, we recommend to give at least 1 gram of tranexamic acid before the 3rd hour after PPH onset. A low dose is ineffective to reduce additional blood loss and to inhibit fibrinolysis in vivo and ex vivo, probably due to the leakage of tranexamic acid in the hemorrhagic flow that is suggested by the pharmacokinetics model. and give a second dose of tranexamic acid after 30 minutes if PPH continue or in cases of major fibrinolysis. Monitor coagulopathy with lab test or viscoelastic test, and treat fibrinogen decrease with fibrinogen concentrate, cryoprecipitate, or plasma. Thank you for your attention.
Thank you, Prof. Sophie. This is interesting because I am also a fan, not of the Beatle, but for TXA.
Both.
both, yeah, both. Because I'm lucky because there is a study maybe 10 years ago about the use of tranexamic acid for trauma, all trauma. And yeah, we found it is endorsed by WHO at that time and started in London, maybe the tropical medicine team. And yeah, luckily we found that it is also helpful for the trauma patient. Now we do it for obstetric. Now we also do for neuro cases. And uniquely now, the surgeon also can put the topical of tranexamic acid in bleeding, not profuse, but small bleeding. They can stop also the bleeding. And there is some question in chat box, in Q&A box. If you want to answer now, it's okay. If you don't want, then we can wait after all the three speakers is.
You are the moderator. You are the chief.
No. You may ask not all, but yeah, maybe some that you think that it's important to everybody listening. Then you can wait until that all three speakers is already finished with.
Okay, very good.
Thank you. And so we can come to the next speakers. My best friend as well, Dr. Nuala Lukas from UK. You may start your presentation.
Thank you, Professor Chandran. Thanks for some fantastic music this morning and sharing this conference with us all. It's been a really fantastic and interesting few weekends. Just getting my talk up. Okay, great. Okay, fantastic. So this morning, I'm going to discuss some hot topics in obstetric anesthesia. Now, I think that we'll all agree that modern anesthesia, and in fact, obstetric anesthesia, is generally fairly safe. And so how are we going to progress our subspecialty? How are we going to really improve the care, of the quality of care and safety for our patients? Well, I think the answer lies with this concept of marginal gains. Marginal gains are not about making small changes and hoping they fly. Rather, it is about breaking down a big problem into small parts in order to rigorously establish what works and what doesn't. So over the next little while, I'm going to hopefully break down the problem of obstetric anesthesia in the context of some new publications and consider how we might make small but evidence-based changes to improve the quality and safety of care for our patients. I'm going to look at some topics related to labor epidural analgesia, and I'm also going to consider some elements of general anesthesia for Caesarean section. So first of all, labor epidural analgesia, risks and benefits, and also I'm going to consider platelet thresholds for the provision of labor epidural analgesia. Now, this study was published towards the end of 2020. I don't want to talk about it too much. I don't want to give it as a scientific manuscript too much oxygen, but it was published in a well-known US journal, and it suggested an association between labor epidural analgesia and the development of autism in children. Now, the study had a number of problems which really undermined its findings. It was retrospective, there were multiple co-founders, there was important between group differences, and there were important exclusions. For example, children not enrolled in health insurance by 1 year were excluded. And of course, these children traditionally are at higher risk of having issues such as autism. Now, why does this matter? Well, because it was published in a well-known American journal, it did receive more attention on social media and other types of media than was justified by its findings and its conclusions. And of course, for women reading this, it would be incredibly alarming. So how can we provide reassurance to women that epidurals in labour are safe? So the first paper I want to discuss was published in JAMA towards the end of 2020 or 2021 last year. It was funded by the Obstetric Anaesthesia Association, and it was a population-based study that aimed to establish and investigate whether labour epidural analgesia was associated with adverse neonatal and childhood outcomes. It looked at over 400,000 mother and offspring pairs, and the outcomes were the need for resuscitation, APGAR score, and neonatal unit admission, and early childhood development. So first of all, if we look at neonatal outcomes and the risks or benefits that epidural analgesia confers. Well, in terms of APGAR score, in those women who had an epidural, there was a reduced risk of their baby having a low APGAR score at 5 minutes. But there was a slightly increased risk of resuscitation and neonatal intensive care unit admission being required. But the authors did something quite elegant. They conducted an analysis for mediation by mode of delivery. And once they corrected by mode of delivery, they found that the reduced risk of a low APGAR score remained, but actually there was also a reduced risk of resuscitation and neonatal intensive care unit admission being required. And I think this is a really fantastic study that does confirm that epidural analgesia is safe for neonates. Now, what about early childhood outcomes? Well, again, they found that epidural analgesia was associated with a reduced risk of having developmental concerns at 2 years. And there were specifically fewer concerns regarding communication and fine motor skills. So my first take-home message is that labour epidural analgesia is not independently associated with adverse neonatal or childhood development outcomes. And if you meet a woman who's concerned about the risks, these particular risks of epidural analgesia, I think you can provide very good evidence-based reassurance that she need not be concerned. Now, what about for our mothers? Does epidural confer any benefits? And of course, as obstetric anaesthetists, we know the great benefits that epidural analgesia can bring. It's not just about pain relief, it's about the ability to convert to anaesthesia for caesarean section. But this group have investigated whether labour neuraxial analgesia for vaginal delivery is associated with a decreased risk of severe maternal morbidity. It was recently published in JAMA, and it's a fantastic study, and I'd urge you to take a look at it. It's a cross-sectional population study looking at over 500,000 women who had a vaginal delivery in New York hospitals over a 7-year period. And their primary outcome was the incidence of severe maternal morbidity, which includes 16 maternal complications and 5 procedures, according to a US-based definition of severe maternal morbidity. And they found that there was a reduced risk of severe maternal mortality associated with neuraxial analgesia, the adjusted odds ratio of 0.86. And crucially, in following on from Ansvi's talk, more than 1/5 of observed association of neuraxial analgesia with the risk of severe maternal morbidity was mediated through the decreased risk of postpartum hemorrhage. So an epidural in labour seems to decrease the risk of postpartum hemorrhage. And I think this is another important evidence-based study that we can use to really provide reassurance to our women. Now I want to move on and talk about platelet thresholds for epidural analgesia. And if I was with you in a room, I'd do a straw poll to look at what your platelet threshold to site an epidural was. And I guess for most people, it would be around about a platelet count of 100. Now, why is thrombocytopenia in obstetrics a problem? Well, we know that if you've got low platelets, you've got a reduced chance of your anaesthesia provider being willing to site an epidural. And of course, that increases your risk of general anaesthesia, which generally we try to avoid. And this nice study from Israel shows the frequency of general anaesthesia in women, in a cohort of women with decreasing platelet counts. And unsurprisingly, the lower your platelet count, the higher your risk of general anaesthesia. But I want to tell you about some updated evidence in this area. So this comes again from the US. It's a recently published guideline about platelet counts and neuraxial anaesthesia in obstetrics. The reference is there, but the headline figure really is this platelet count of 70,000 is likely to represent a low risk for spinal epidural hematoma. Now, I want to demonstrate to you why I believe the platelet count of 70,000 should be our new cutoff to provide epidural analgesia. Now, this guideline was based on a number of papers, and I want to pick out one of the best papers from their review. It's from a perioperative outcomes group in New York. And what they did was they looked at epidural hematomas in a cohort of patients from across their hospitals. And they combined their data with systematic review data from the literature. They divided their patients into three thrombocytopenic groups. Those women with 0 to 49,000 platelets, 50,000 to 69,000, and 70,000 to 100,000. And first, they looked at, as I said, they combined their own clinical data. It was retrospective, but it was genuine clinical data with data from the literature. Now, first of all, the frequency of epidural hematoma across those three cohorts. There were no epidural hematomas in any of those three thrombocytopenic groups. But then they did something quite elegant. They calculated confidence intervals for the risk of epidural hematoma across those three different groups of thrombocytopenia. And you can see that in the 0 to 49,000 group, the confidence intervals were quite broad, 0 to 11. But once you got down to 70,000, greater than 70,000 platelets, the confidence intervals narrow nicely. And I think this does demonstrate and provide fantastic reassurance that 70,000 platelets should be our new cutoff for the provision of epidural analgesia. So just to summarize, as I said, 70,000 is the new count. I think this is a reasonable figure to use in patients with gestational thrombocytopenia or hypertensive disorders. There are some other causes of thrombocytopenia, and I think in those instances, it's useful to undertake another assessment of coagulation before you site the epidural. I think, as we all know in anaesthesia, it's not just about absolute values, but it's about the trends and likely trajectory of a platelet count. And I just want to give you a couple of examples to consider. If you think about a woman who's got gestational thrombocytopenia, she's potted along through her pregnancy with a platelet count of between 70 to 80,000. Now, I want you to consider a patient with preeclampsia who was admitted, say, for 3 days ago, and her platelet count was 110. And then yesterday, her platelet count was 80. Now, I think that that second patient actually presents a much greater risk of perhaps epidural hematoma than the first patient because she's got a rapidly falling platelet count. So I think, as we always do in anaesthesia, it's really important to consider the trends and the possible trajectory of the platelet count. And the last point I want to make is that it's really important to think about timing of removal of the epidural catheter because the risk remains for removal as well as insertion. Now I want to move on and just discuss some issues around general anaesthesia for caesarean section. Now, as anaesthetists, we all believe that general anaesthesia is associated with a higher risk than spinal or epidural anaesthesia for caesarean section, but actually the evidence about this is relatively limited. But this nice study has been published a couple of years ago. It's a retrospective study from the US that looked at adverse events and factors associated with potentially avoidable use of general anaesthesia in caesarean delivery. It looked at a cohort of patients from New York State hospitals over a 10-year period. And they looked at caesarean deliveries performed with general anaesthesia, but where there was no recorded indication for general anaesthesia. So potentially of what they describe as potentially avoidable general anaesthesia. The adverse events they looked at were anaesthesia complications, infection, and thromboembolism. And from their cohort, they identified over 26,000 cases, just over 5% of their total, that were completed without recorded clinical indication for general anaesthesia, so avoidable general anaesthesia. And across a range of complications, anaesthesia complications, surgical complications, and venous thromboembolism, there was an increased risk associated with avoidable general anaesthesia. So compared with neuraxial anaesthesia, avoidable GAs are associated with increased risk of adverse maternal outcomes. Now, what about the impact on the neonate and early childhood outcomes in women who have received general anaesthesia for caesarean delivery? And again, I'm going to come back to another population-based cohort study from Scotland, from Rachel Kern's group. Population-based study looking at more than 140,000 live births. And they looked at women who'd received general anaesthesia, epidural, and spinal anaesthesia. So when they compared neonatal outcomes in women who'd received general anaesthesia versus spinal anaesthesia, that there was an increased risk in terms of a reduced APGAR score at 5 minutes, neonatal resuscitation, and NICU admission. And this was whether the woman had an emergency general anaesthetic or elective general anaesthesia. But if you look at this column here, in those women who'd had elective general anaesthesia, the risks were significantly greater. The risk ratios were much more significantly increased compared to women who'd had general anaesthesia in an emergency context. And this is a small but crucial point, because sometimes I wonder, in an elective setting, is that general anaesthetic avoidable? Now, what about early childhood outcomes? Well, they did find that there was a weak association between general anaesthesia in emergency cases and having more than one developmental concern noted at 2 years. So my take-home message here is that general anaesthesia adverse associations are strongest in non-urgent caesarean section at term. This is when the fetus is least likely to have pre-existing problems. And I think we really need to scrutinise the context and setting and the reasons behind why we're administering general anaesthesia in the non-urgent setting. Now I want to move on and talk about some airway issues associated with general anaesthesia. These 3 papers have been published over the last 18 months or so. The first comes from France, Frederic Mercier's group, and they looked at the incidence and risk factors for maternal hypoxemia during induction of general anaesthesia for emergency caesarean section. And they observed a relatively high incidence of maternal hypoxemia, around 10%, with unsurprising risk factors of difficult or failed intubation and an induction agent other than propofol. The second study comes from South Africa, a similar methodology, and again, they observed a relatively high incidence of maternal hypoxemia, around 16%. And the third study is some work I was involved in the UK. Again, we didn't look at hypoxemia, but we did confirm the relatively higher rate of difficult tracheal intubation in obstetric patients. Now, what was interesting about these 3 studies is that although each of them confirmed a higher rate of airway complications associated with general anaesthesia, videolaryngoscopy was very, very infrequently used in each of these 3 studies. So my next take-home message is that general anaesthesia is associated with a relatively high rate of airway complications, but videolaryngoscopy is used infrequently. Now, the final study I want to talk about with regards to general anaesthesia before I bring all of these studies together is some work that comes from the UK, and it was looked at the management of caesarean sections during the first wave of the COVID pandemic. It was a cross-sectional analysis of 6 hospitals in the northwest of England. And they looked, their primary outcome was a change in general anaesthesia during the first wave of the pandemic in the UK compared to a similar time period in the preceding year. And their secondary outcome was caesarean section rates and regional to general anaesthesia conversion rates. So they found that during the first wave of the pandemic across these 6 hospitals, there was a decrease in the GA rate, a significant increase in the GA rate for caesarean section. There was a small but non-significant increase in caesarean section rate. And when they looked at their regional to general anaesthesia conversion rates, again, there was a decrease in the first wave of the pandemic and a small decrease in category 1 caesarean section. So in conclusion, they found while there was a small increase in caesarean section rate, there was actually a decrease in the GA rate. And this was driven by increased consultant presence and increased consultant decision-making. So how can I bring all of these studies together to give you some firm conclusions about how we should consider general anaesthesia for caesarean section? Well, I think we do have good evidence that general anaesthesia is associated with a higher rate of maternal complications and can be associated with a higher rate of adverse neonatal outcomes. So what can we do as obstetric anaesthetists? Well, I think first of all, we need to avoid unnecessary general anaesthetics. And I think this really underlines the role of senior decision-making. But I do want to emphasize that we must also concentrate on delivering safe general anesthesia. As anaesthetists, we must never shy away from delivering a general anesthetic when it's really needed in those true category 1 scenarios where you have a fetal bradycardia, for example. But what we need to do in those settings is to make it as safe as possible. And I think this point about using propofol isn't really relevant outside the UK. I think most people use propofol outside the UK, but propofol and videolaryngoscopy do seem to confer a degree of safety. Now, the last thing I really want to discuss is the issue of post-Caesarean section analgesia, and in particular consider the role of abdominal wall blocks. Now, we know that neuraxial opioids, morphine, diamorphine, given by the spinal or epidural route, confer really the gold standard as the basis for post-Caesarean section analgesia, and they're recommended by many international bodies. But regional anaesthesia, of course, has been an important element of our practice, and discussion continues about the role of abdominal wall blocks, tap blocks, quadratus lumborum blocks, and ilioinguinal iliohypogastric nerve blocks in the provision of post-Caesarean section analgesia. So I want to try and summarize the evidence that we've got to date. Now, the best evidence is available for tap blocks. So if you look at a group of women who've received this systematic review data, group of women who've received tap block versus those who haven't received tap blocks. And if you look at the outcomes of pain at rest and pain with movement, well, without neuraxial opioids, tap blocks definitely seem to confer benefit in terms of reduced pain at rest and pain with movement. However, as soon as you compare tap blocks in those women who've received neuraxial opioids, there is no longer any benefit conferred, with the majority of the benefit provided by intrathecal or opioids. And these findings are pretty consistent whether you consider tap blocks or quadratus lumborum blocks. Just to summarize, when you're comparing tap or quadratus lumborum blocks versus control, patients who haven't received neuraxial opioids, they definitely seem to confer benefit. But once you add intrathecal or epidural opioids into the mix, that benefit is removed. And if you give tap blocks or quadratus blocks to those women who have received intrathecal opioids, there is no difference. So is that the end of the story for abdominal wall blocks and post-Caesarean section analgesia? Well, not quite. This interesting network meta-analysis, which we know is an evolution of the meta-analysis technique, allows multiple comparisons, has recently been published in Anesthesia. They looked at a range of abdominal wall blocks, tap blocks, QLB blocks, ilioinguinal hypogastric blocks, erector spinae, and local anaesthetic wound infusions and infiltration. And their primary outcome was mean morphine consumption in the first 24 hours postoperatively. And interestingly, this review did find that the ilioinguinal iliohypogastric nerve block did confer benefit in terms of reduced morphine consumption in the first 24 hours post-op. And this effect persisted even in the presence of neuraxial opioids. So that's distinct from the findings related to tap and quadratus lumborum blocks. Now, I think the evidence for this is somewhat limited. This is encouraging, but still, I think, not compelling enough that we should be using this particular block on every Caesarean section patients. So I think what we need to do as a subspecialty within anaesthesia is I think we need to continue this discussion and investigation. And I think further studies are definitely warranted. And perhaps we need to consider defining the role of abdominal wall blocks, perhaps not in all patients, but perhaps in women who've received general anaesthesia or in patients who are at higher risk of post-Caesarean section pain. And we know that some women are at high risk of high levels of post-Caesarean section pain. So just to conclude, labor epidural does confer benefit in terms of improving neonatal and early infant outcomes. It reduces severe maternal morbidity, particularly in regards to postpartum hemorrhage. And I think we need to reevaluate our platelet thresholds for epidural analgesia. And I think 70 should generally be the new cutoff, with the caveats I mentioned about considering the trends and trajectory. Lastly, general anaesthesia is associated with a high rate of maternal complications and can be associated with a high rate of adverse neonatal outcomes. And this behoves us to consider strategies to decrease its use. We shouldn't be using general anaesthesia unless it is necessary, but we also need to make it safer. So I hope I've demonstrated a few marginal gains that you can perhaps adopt into your practice to try and improve the quality and safety of care for our patients. Thank you very much for listening, and thank you again to Prof. Chandra and the whole community for asking me to speak today.
Thank you, Nuala. My Indonesian flag is there. Thank you very much for that. Yeah, we have so many things that we can discuss, but unfortunately, I just realized that there will be no Q&A session. So, Anne and Nuala, I hope that you can answer directly in the Q&A box, because we are running out of time. And hopefully that the questioner, the participant who make a question will be happy if you answer all their question. And we come to the third speaker, my best friend from 2006, maybe, long time ago. He teach us how to do a fire drill of obstetric emergency. So we do it now every 6 months for our resident, not just anesthesiology, but also the OB/GYN. Without further ado, Mike Kinsella will talk about nightmare as an obstetric anesthesiologist. Mike.
Thank you very much, Cecilio. I'm going to try and share my presentation with you all.
Yes.
Is that okay?
Yes, nice.
Okay, right. Thank you very much, Dr. Cecilio and the organizing committee for this invitation. So I'm going to be talking about something which really I shouldn't be talking about, coming from the UK, which is a rich country, which has a service provided almost 100% by medically trained anaesthetists, and we have plenty of money for monitoring equipment. Really, we should be have moved on from the problems of esophageal intubation. However, this is what my talk is about today. So I don't have any conflicts of interest. And now I'm trying to move on. Right. So this is a graph of maternal deaths from anaesthetic causes from the UK confidential inquiries into maternal deaths. These are published covering a 3-year period, so over something like 70 years or so. The middle year of each period is marked by a bar there. So 1953 covered the deaths from anaesthesia from 1952 to 1954. You can see that the overall death rate has declined significantly. Regional anaesthetic deaths play a small part, although an increasing proportion as the total number of general anaesthetics have declined. If we take out the regional deaths, clearly the pattern is going to look very similar. And here I've highlighted the deaths from aspiration, which played a prominent role in the early years, but have almost disappeared now. So the remaining causes, there's a variety of problems, but airway management problems play a significant role there. When we look at obstetric general anaesthesia versus non-obstetric general anaesthesia, there are higher risks for various problems, just as Neil has highlighted. And a review that we did a few years ago suggested that the rate of failed intubation hadn't changed over 35 years. One front of neck procedure per 60 failed intubations, and one death per 90 failed intubations. So looking at some of the individual cases from those confidential inquiries of esophageal intubation. So in the 1982 to 1984, there was a case which was sort of fairly typical of the time, where there was difficult intubation, repeated attempts at trying to intubate. And at that time, What we weren't emphasizing was that it was important just to maintain oxygenation with mask ventilation. Laryngeal mask airways weren't available to secure the airway as well. The next one, 1985 to 87, this is a very sort of sad situation where the anaesthetist was concerned that the tube was in the wrong place, but because they had such a struggle passing the tube, they were inhibited from taking it out. And so the patient died with the tubes still in the wrong place. The next one from the same maternal report, blind intubation. Clearly, that's often the case when you can't see the glottis, you're more likely to get an esophageal intubation. And unfortunately, the succinylcholine wore off, but the long-acting muscle relaxant was given, and the tube was only taken out after cardiac arrest. Then 2000, 2002, there were another 3 cases, and I'll come back to one of those in a little while. And this is a sort of the period. So around 2000 was the time that I think we thought, this is never going to happen again. It's not going to be a problem again. So the Royal College of Anaesthetists issued a statement, 1998, that no trainee should provide general anaesthesia without capnography. And then they sort of made it more general a couple of years later. All anaesthetists should have this monitoring available. And at that point, problem solved, in theory. How do we confirm tracheal tube placement? This is a nice study performed a number of years ago, where the anaesthetist passed a tube into the trachea and also one into the esophagus, and then they checked the methods for determining placement using these 2 tubes. What was reliable was either listening in the axillae for breath sounds and listening over the epigastrium, as well as the esophageal detector device, which is a 50 ml syringe connected up to the tracheal tube. And if you can aspirate 50 mils of air easily, then you'll be in the trachea, not in the esophagus. And these other signs were not reliable and really shouldn't be counted on chest or abdominal movements and condensation in the connectors. These days, we may have availability of this technology that can reassure us by checking directly. So either looking around the corner with a video laryngoscope to see if the tube is passing through the glottis, or using a fibroscope, passing it through the tube, and then looking for tracheal rings beyond the tube. But the gold standard is capnography. Just to terminology, a capnograph is the instrument that measures expired carbon dioxide, and a capnogram is a visual trace of instantaneous carbon dioxide in the sample. So usually you'll see capnograph being mentioned, but this is what a capnogram is. The Association of Anaesthetists have just recently updated their guidelines on recommended monitoring. Capnography should be available from beginning to end of general anaesthesia. It should be available when there's deep sedation. It should be available when an anaesthetized patient is being transferred from one area to another. It should be available on intensive care units, as well as during cardiac arrest. And this is just a quick search. capnography can be quite expensive, but there are some cheap monitors available, and this is really one of our most significant monitors for patient safety during general anesthesia, and really we should have them available. And why is capnography so good? Well, it actually tells us an awful lot about physiology. It tells us about VQ mismatch. It can tell us, detect air embolism. We can adjust our tidal ventilation using it. Besides the fact that it at the beginning of anesthesia, at induction, detection of misplacement of the tracheal tube. So carbon dioxide is produced in the cells, circulation transfers it to the lungs, ventilation transfers the carbon dioxide through the trachea and then into the ventilation circuit. In the UK for a few years, we've had a no trace equals wrong place campaign. Does that mean that if you have a trace, you're in the right place? Well, it's almost, it's very difficult to get false positives. So the Coca-Cola complication has been described if a patient drinks a lot of carbonated beverages just before induction of anesthesia, they may have carbon dioxide in their stomach. But after about 6 tidal ventilations, that will have almost completely disappeared. The other thing is misplacement after correct placement. So you may see a capnograph trace at the beginning of anesthesia, but you do need to keep checking that that it doesn't disappear, that it is still there. No trace equals wrong place. Well, you do have to exclude some aspects before you can conclude that that it's in the wrong place, the tube's in the wrong place. So what are these false negatives? Well, if we look at cardiac arrest, the NAP4 project emphasized quite clearly that if you have cardiac arrest and you are performing CPR, then you will have some transfer of carbon dioxide from the cells to the lungs. You will have some detectable trace. It's going to be very abnormal with low end tidal levels, but there will be some there. So if you have a completely flat trace during cardiac arrest, you cannot assume that this is the tube's in the right place. Very tight anaphylaxis or bronchospasm. This can occur, but it's exceedingly difficult to find cases where there is absolutely no ventilation possible at all. And the maternal mortality report from 2009-2012, here the anaesthetists were presented with such a case. In fact, they were concentrating on the fact the tube might be in the wrong place as a cause of impaired ventilation. So in a sense, they were doing what we're taught to do to check and be suspicious of tube placement. However, they didn't consider alternatives, and that's something that in our practice, when things are going wrong, we always have to recheck the diagnosis. There may be problems with your ventilation circuit for various causes. When in doubt, the important thing to do is to get a self-inflating bag connected up to the catheter mount or the tracheal tube. And a self-inflating bag should always be present as an emergency backup whenever we're providing general anesthesia. So the other thing is, if you've got problems with getting the sample out and into your capnograph where you're doing the measurements. So there could be a number of problems. So the sampling tube can be disconnected or blocked. This is a picture from a recent letter showing on the right-hand side, you've got the sampling tube, which is blocked, which caused some diagnostic problems to the anaesthetist until they'd worked that through. And checking the capnograph before starting is a very sensible precaution. Okay, so then we get on to the true negatives, the no trace is in the wrong place. So esophageal intubation. This case, 2006 to 2008, the anaesthetist failed to intubate. They passed an intubating LMA, and at this point, the patient was being oxygenated and was relatively safe. And we would normally suggest that you either wake up or potentially strongly consider continuing with the laryngeal mask. However, the anaesthetist passed the tube blindly through the ILMA, but it was into the esophagus. The flat capnograph wasn't detected. Again, the patient becoming hypoxic, starts to move, but is given a muscle relaxant so they can't move anymore, leading to death. And then this, another problem or combination of problems, esophageal intubation occurred. It was quite a difficult induction, and there'd been regurgitation. And the anaesthetist knew that there were gastric contents in the mouth, and they assumed that the flat trace was a monitoring problem. So again, they fixated on the one aspect and didn't reconsider and recheck the fact that the tube was in the wrong place. You've seen that over the past few years, there may be only a small handful of deaths in every 3-year period from anesthesia in obstetrics in the UK. So it's become difficult to provide anonymous, detailed reports of these deaths. However, we can learn from public examination of cases going through the UK coroner system. This is about 130 years old. It was set up to look for foul play, really, in deaths, but it also examines medical mishaps. And a coroner will hold an inquest, which is a public case. The reports are published and available, and the press, the local press or the national press, may also attend cases that they consider may be interesting, so it may get into the newspapers as well. And the coroner can write what's called a Regulation 28 report if they feel that there's lessons to be learned that could reduce the risk of problems recurring in the future. They can write a report to send to the head coroner, and the head coroner can then make other health bodies aware of this. So I'm cheating a bit. This is not an obstetric case, but it's a non-obstetric case which occurred a death in the year 2000, which has caused much soul searching in the UK. It was a healthy 60-something-year-old lady having an appendectomy. Anesthesia was induced, ventilation was easy. Theatre practitioner attempted intubation and failed, and the consultant in charge of the case took over. The tube was passed in the esophagus. Ventilation wasn't possible, and hypoxia developed. And the lead anaesthetist thought this was anaphylaxis and treated that and continued to treat that. And it was only finally after 11 minutes when another consultant who'd come along checked and detected the esophageal intubation. However, she had unfortunately suffered irreversible brain damage and subsequently died on intensive care. So the Macintosh laryngoscope was used for all attempts, suggesting that it wasn't necessarily an exceedingly tricky intubation. And capnography was available throughout all this period. The coroner highlighted a couple of things. One was a failure of standardization of the monitors. And I'll go through this with this this is a picture of just a generic trace showing a pressure waveform at the top and a capnograph trace at the bottom. Now, in this hospital, this was not the default screen. The anaesthetist had to dial up the carbon dioxide trace, the capnogram, onto their monitoring manually. So this is what you get if you didn't do that. You had a screen which showed a phasic waveform, and in the panicked situation, people were looking at that waveform and assuming it was a capnogram. So just to re-emphasize, this was a case of mistaken identity. So I said, if you've got a trace, it must be in the right place. Well, this is absolutely clear. If you've got a normal carbon dioxide trace, you have to be in the trachea. But if it's a case of mistaken identity, then you could be led astray. This is a sort of pretty small print stuff, but if problems can happen, we know that they will. There were other aspects concerned with the management of the case. So the coroner felt that there'd been fixation on the anaphylaxis and that nobody had gone back to consider whether there were any other problems. The team didn't work properly. Chaos and panic, blindness by the lead anaesthetist, and inhibitory hierarchy. And so this picture is the helicopter view, which is promoted in teamwork. So the fact that there should be somebody who is not too involved in the case, who can stand back and consider alternatives rather than the fixation on one particular pathway, which is very, very easy for us to do in a crisis. There's been a lot of research on teamwork in the past few years, especially done in simulation centres. So the promotion of speaking up by the team, and you can easily find the literature on this. This is just a recent review. but suggesting that we can address the problem. So barriers can be modifiable, and promoting teamwork and open culture is possible. And Cecilia's mentioned the fact that in Indonesia, this has been taken on very successfully and openly, which is really fantastic. We can teach other people besides medical anaesthetists what we should be looking for, and this was just a simple scheme for teaching intensive care nurses what a capnogram should look like. So basically, a top hat is good, other hats or no hat is bad, and I thought they might be modifiable for Indonesian hats as well, potentially. This editorial, very interesting editorial in Anesthesia from a couple of months ago, is freely available to read, discussing this Logsdale case that I've been talking about. But one of the things they are suggesting is the potential for technology, smart technology within our monitors to be able to detect this problem. So on the left, there are various different patterns of pressure and carbon dioxide waveforms. But I'm highlighting on the right-hand side at the top, clearly, if you've got a regular pressure trace and a flat capnogram, then your alarm will sound at the bottom right. If you've got a regular pressure trace and a regular capnogram, then you're in the right place and you can be reassured. But there may be other situations, for instance, if you've got irregular traces of pressure and carbon dioxide, this may relate to mask ventilation at the point of induction of general anesthesia. So your alarm doesn't sound for a while until the situation settles or there's a timeout. So my conclusions from this, capnography is essential during general anesthesia, and in the UK it's now mandated for almost every situation where patients are not able to maintain their own airways and breathe spontaneously. We need to be familiar with the technical aspects of sampling. We need to be very familiar with how to interpret a capnogram. And we should also, the people that work with us in the operating theatres and intensive care should also have an understanding of this. It's not just a solo, patient safety is not just a solo procedure for the anaesthetist on their own. Video laryngoscopy is clearly useful for the process of tracheal intubation, as Nuala mentioned. But the other thing about it is that if you've got a screen that other people can see, then it becomes a shared process. And again, other people in the theatre team besides the anaesthetist understanding what's going on and being able to comment improves safety. Teamwork, the ability to speak up when things are going wrong, considering alternative diagnoses in the event of crisis is absolutely crucial. And we may have some technological advancements in the future that will help us to ensure this doesn't happen again. So there's the references and my email in case anybody wants to contact me. Thank you very much.
Thank you, Mike. This is very important because we are still facing this problem in obstetric anesthesia till today. So I think we still have 2-3 minutes to do a Q&A session. Firstly, I would ask Prof. Anne Sophie about highlight again about the possibility in using TXA for prophylaxis when we are doing anesthesia for C-section. We know that there is possibility of bleeding, only possibility, normally not. What is your comment about this? You still mute your mic.
I underlined the intense research effort on tranexamic acid, and what prophylactic use is now not recommended for all cesarean section. And there are two very interesting trials who are running in to select a better population to administer tranexamic acid prophylactically. The first trial is a trial of Loïc Santil in placenta previa patient with abnormal placental insertion. And this trial is running. And the second trial is a woman trial for to use prophylactically tranexamic acid by oral way or intramuscular way in all patients, vaginal delivery and cesarean section, to have a better timing of administration and to make it easy in each country, everywhere, by all midwives to use tranexamic acid for patients in the world. So actually, we cannot recommend to use prophylactically tranexamic acid in all patients. What we do is to administer tranexamic acid when bleeding is beginning, and we measure it very closely with aspiration bags and also under buttock bags, even in cesarean section.
Yes,
is it okay?
I think it's important for our audience that no place to do prophylactic in cesarean section, and yeah, we are still waiting for the study. Maybe next year there will be another things to
very quickly tranexamic acid if bleeding is beginning.
Okay, thank you. And the second question for Nuala and Mike is about the use of LMA in general anesthesia. Why both of you seems that not in favor to use it? Is there any comment from you both?
Okay, I'll go first.
Usually ladies first. Okay, no problem.
You can see from the UK that we have concentrated very, very much on safety in anaesthetic practice. That can tend to lead to a situation where we're not very flexible and change happens slowly. So we know that there are some very interesting case series, especially from Asia, where laryngeal masks have been used for elective cesareans and even category 3 cesarean sections with very good results. So that is clearly, I mean, I believe that's something we may be doing in a few decades' time. but currently it's not part of our what we're contemplating in the UK. At what point does the pregnant woman become so pregnant that she requires a tracheal tube? People have different thresholds. I think in my hospital we're around 20 weeks or so, but clearly the data there is slightly less easy to interpret, and I mean, we know that it is harder to ventilate a term pregnant woman who has a large uterus. So a laryngeal mask is more appropriate much earlier in pregnancy from that regard. But sorry, Nuala.
Thanks, Mike. No, well, I agree with everything that Mike has said. I think when we talk about using laryngeal masks in the obstetric population, I think we need to make the distinction about what stage of pregnancy. And I think Mike's point out cut off around about 20 weeks, I think is a reasonably pragmatic one, because not all pregnant women are the same. I suspect that the answer lies somewhere in the middle, and I suspect that in years to come there will be scenarios where using a laryngeal mask for some types of obstetric surgery will be acceptable, and in some types of patients, so patients with normalish BMIs, people who've been fasted. But just in general terms, not just with regards to obstetrics, I think that we overuse supraglottic airways, laryngeal masks, eye gels these days. And if I consider, the early part of my anaesthetic career where the choices were face mask ventilation or intubation, and I think I was probably much better at face mask ventilation there, and possibly even, I think the years have contributed to experience now, but I think that we saw failed intubation much less frequently because we were all doing it much more frequently. And I think this world of difficult and failed intubation, I do wonder if we have contributed to it by our ubiquitous use of supraglottic airways. And if you think about general anaesthesia in obstetrics, we actually do it very infrequently. It's already associated with, I think, a fair degree of anxiety because of the situations we're doing it in, and the potential outcomes and complications that can occur. And personally speaking, I like the comfort of having an endotracheal tube, knowing that that airway is secure, and the various problems that I'm going to be managing around general anaesthesia and obstetrics, that's hopefully at least one of them, that once I've got the tube down, it won't be a problem. So I think there probably is a role. I think we need to define what we mean by obstetric, do 20 weeks, 25 weeks, 30 weeks. But I also think we just need to have a balanced approach to using supraglottic airways in general. And I think just because we can doesn't mean we should. And the very final point I would say is that I do recognise there's been some excellent work from parts of Asia with large case series. And I think this is why we do need to scrutinise and not just completely dismiss it, but I will personally be a bit conservative about it.
Thank you for this. This is very important, that we know there is so many possibility happen. Maybe we should do more study on this. So I think we can wrap up this meeting. Thank you, Anne, Sophie, Nuala, and Mike for always contributing to Indoanesthesia. And I think, we can say that this is the very last words that we can.
Ya, tuh kok masih ada beneran. Saya pikir cuma masang aja.
Ed, kedengeran Ed. Okay. And for closing this old session, I will say, as Krisha already mentioned earlier, the Indonesia will traditionally open and close symposium with the obstetric anesthesia. So we come to the end of the 19th Indoanesthesia 2022, I believe. During these 4 weeks, we have obtained the fruitful discussion We have learned a lot from amazing speakers coming from all over the world. On behalf of the committee, thank you for all speakers. Thank you for all three today. Furthermore, I would like to thank all participants who joined this meeting from all over the world. I sincerely hope that through this meeting, all of us can contribute to better anesthesia and critical care in the world, particularly in Indonesia. Thank you for our sponsors who continue to support Indoanesthesia. Finally, I would like to thank all committee members, band members, the teams who work behind the scene, who have ensured the symposium proceeds smoothly. Thank you and see you next year.